support. Whenever there is a failure of the lung or heart, by putting the ECMO, we are giving time for those organs to recover. So before initiating the ECMO, we have to have an exit plan, and the same plan we have to discuss with the family also. Because sometimes the organ can recover, sometimes it may not recover, and we can go ahead with the transplant also. So all those options we have to discuss with the family before going to the initiating the ECMO itself. So before initiating the ECMO itself, we should have an exit plan, which is must. Because it is not the end, it is just a bridge for either recovery or transplant. So before going into the details of ECMO, we need to know certain physiology about the oxygen delivery and oxygen consumption. So our entire ECMO, being it a VV or VA ECMO, will depends on the oxygen delivery and oxygen consumption. So we know that oxygen delivery is around 1000 ml per minute, whereas our consumption at the arterial level is only 250 ml. So the DO2 by VO2 ratio is around 1:5. So whenever there is a requirement or whenever there is a mismatch, or either increase in the oxygen consumption or decrease in the oxygen delivery, to some extent our body will accommodate by increasing the oxygen extraction ratio, because there is almost 5:1 ratio will be there, DO2 by VO2. So our body will compensate by increasing the oxygen extraction ratio until it drops down to 2:1. So if the DO2 by VO2 ratio drops to 2:1, this is the critical level. At this point, there is a huge demand supply mismatch, so our body cannot tolerate, and tissues will go into anaerobic metabolism, and then the lactic acidosis will set in. Until that point, our body try to compensate. So at that point, the organs started failure. So our main goal of ECMO is to preserve that DO2 by VO2 ratio at least 3:1, so that we can prevent the anaerobic metabolism and we can maintain the tissue perfusion. So that is our main goal of ECMO, being it a VV ECMO or VA ECMO. So the main types of ECMO are veno-venous ECMO and veno-arterial ECMO. So veno-venous ECMO, it mainly supports the lungs. The patient should have a normal cardiac output in this. Veno-arterial ECMO, here it will support the heart and lungs. So what are all our main goals in initiating the ECMO? It is maintaining the adequate oxygen delivery to the cells and maintain the tissue perfusion. At the same time, we will prevent ventilator-associated lung injury in cases of severe ARDS, and will give rest to the failing organs like heart and lung to promote healing. And at the same time, by supporting the heart, we can reduce the toxicity due to very high inotropic supports. So this is the main hardware involved in the ECMO. So if you can see, this is the main console. So these consoles vary depending upon the company. And then comes the pump, which is a centrifugal pump. It will create a negative pressure and sucks blood from the patient, and then that blood will goes to the oxygenator. In the oxygenator will have in the oxygenator, the blood will get oxygenated, and at the same time, because of the sweep gas effect, the carbon dioxide removed from the blood, that oxygenated and decarboxylated blood will go to the patient. So this is how ECMO will work. So this circuit is about the VV ECMO, veno-venous ECMO. So if you see, in the first level, when we'll put a cannula in the femoral side, so from there the pump will suck the blood from the femoral vein and will give that blood to the oxygenator. There you can see the oxygen and air blender. So through that oxygenator, oxygen and air will go, the blood will get oxygenated and carbon dioxide will get removed, and the same after oxygenating the blood, will give that blood back to the venous system in a VV ECMO. So in this VV ECMO, the right side of the heart will receive the oxygenated deoxygenated blood. Usually we'll have a deoxygenated blood on the right side of the heart, but in VV ECMO, as lungs are not working properly, so our right side of the heart will receive the oxygenated blood, and that blood will goes to the lungs. Through lungs, it will enter the left side of the heart, and then it goes to the tissues. That is why for VV ECMO, we need a normal functioning heart before initiating. So that is why the arterial oxygen saturation in VV ECMO depends on the ECMO flow and the native cardiac output. Usually our target is to maintain saturation of around 85 to 90%, which is acceptable. And our main aim is to maintain the oxygen delivery. So this is the circuit about the veno arterial ECMO. Here we will take out the blood from one of the major veins, usually the femoral vein, and then again it will go to the oxygenator. The same process, it will get oxygenated and carbon dioxide will be removed. But here we will give that blood back directly into the arterial system, so that it will augment the failing heart. It will augment the cardiac output, so that it will support the failing heart, which is unable to maintain the cardiac output to the tissues. So this is the mechanism with the VA ECMO. So here we will give directly into the arterial system, whereas in the venous ECMO, directly we will give the oxygenated blood into the venous system. So these are the certain differences between the veno-venous and veno-arterial ECMO. So basically veno-venous, it supports the lungs, veno-arterial, it supports the heart and both lungs. So the pump flow or blood flow is slightly higher we will use in veno-venous ECMO compared to the veno-arterial ECMO. If you see the arterial waveform, as we will take out the blood, the cardiac output is very less. The flow is non-pulsatile in VA ECMO, whereas the flow is normal because the cardiac output is normal in VV ECMO. So the right side of the heart, usually in VV ECMO, it receives oxygenated blood, whereas in VA ECMO, it receives normal non-oxygenated blood only. So what are all the indications? So for veno-venous ECMO, severe ARDS is one of the main indication. Whatever may be the underlying cause for severe ARDS, being it a primary ARDS or secondary to any other condition, if the patient is having severe ARDS, means the PaO2 by FiO2 ratios for less than 50 for more than 3 hours, or if it is less than 80 millimeters of mercury for more than 6 hours, is an indication for initiating the ECMO. Even with the hypercapnic respiratory failure, despite of adequate ventilatory support, still patient is having pH of less than 7.25, PCO2 of more than 60, still we can consider VV ECMO. For only isolated hypercapnic respiratory failure, there is an entity called ECOR, extracorporeal carbon dioxide removal entity is there, that one we can use. And as a bridge to lung transplant also we can use VV ECMO. Whereas VA ECMO, any kind of cardiogenic shock, there can be maybe due to acute MI or acute myocarditis or whatever may be the cause. If there is a severe cardiogenic shock, we can have a VA ECMO. Even refractory arrhythmias which are not amenable to the treatment, post-cardiotomy failures, or unable to wean the patient post-operatively from cardiopulmonary bypass, or if there is a massive pulmonary embolism leading to severe cardiogenic shock also, we can initiate a VA ECMO. So what are all the absolute contraindications? So if there is an unrecoverable heart or lung without any transplant, and if the family is not willing for the transplant, is absolute contraindication. And if there is any catastrophic or irreversible brain injury, unwitnessed cardiac arrest, especially for more than 60 minutes, if there is a severe aortic dissection, especially for VA ECMO, these are all absolute contraindications for initiating any sort of ECMO. The relative contraindications, advanced age, they'll say usually more than 75 years is an absolute contraindication. But if the patient is otherwise fine, doing his daily activities normally, still we can consider ECMO in those patients also. That is why it's a relative contraindication. Even in uncontrolled hemorrhage also, depending upon the condition of the patient, still we can consider depending on the severity of the hemorrhage. Same with the mechanical ventilation for more than 7 days. This is also a relative contraindication, not an absolute contraindication. So as we are taking the blood out and the blood passes through the extracorporeal circulation, we have to prevent thrombosis. That's why these patients will need anticoagulation. So because of anticoagulation, always there will be a chance of bleeding. So we have to maintain a tight rope between the thrombosis and anticoagulation. So usually these patients, we will start them on unfractionated heparin infusion, and we will monitor the ACT levels to maintain ACT around 180 to 220 in these patients. Depending on that, we will maintain our heparin infusion. Especially for VV ECMO, whenever we are initiated VV ECMO, we'll keep the lungs in a rest settings because lungs has to heal, and our main aim is to prevent the ventilator-associated lung injury also. So for that, we'll keep the lung in a lung rest setting. Usually, we'll keep the patient on around 4 ml per kg of predicted body weight tidal volume. PEEP should be around 10 to 15 millimeters of centimeters of water to keep the lungs open and to prevent atelectasis, and FiO2 will keep minimum of around 30 to 40%. Whereas in VA ECMO, we'll keep the patient on normal lung protective ventilation settings only. So how will we monitor the patient while the patient is on ECMO? We should have a checklist. We should never leave the patient unattended, and daily we have to go through this checklist, and we have to see all these things are properly monitored or not. We have to check the machine, all the circuits. Daily we have to check the circuit. We'll say torchlight test. So from starting the site of insertion to the entire length of the circuit, oxygenator, even pump also we have to check for any clots or any change in the color. Daily these things we have to check, and we have to properly secure the cannula, and we have to keep certain things ready. Extra like battery, hand cranks and clamps, all these things we have to keep ready, along with some PRBC also we have to keep ready for emergencies. These are the daily checklist for monitoring the patients who are on ECMO. So there can be some mechanical complications we can see in patients who are on ECMO. So there can be a pump failure or oxygenator failure. There can be always a chance of air embolism. So we have to carefully monitor the patient for these complications. We have to get prepared every time whenever we see all these complications, because these are very catastrophic and we can lose the patient also. So the bleeding risk is very, very high when the patient is on ECMO, because we will give anticoagulation. The mortality because of bleeding is almost around 30 to 40%. Patient can bleed anywhere, right from intracranial to chest or even GI bleeds. Patient can have bleeding anywhere in the body, and which can be catastrophic also. Because blood is passing through the extracorporeal circuit, there is always a chance of hemolysis. Especially for VA ECMO, we will put a cannula on the femoral side. So always there can be a chance of limb ischemia. So that is why for VA ECMO, usually we'll put a distal perfusion cannula also to prevent the limb ischemia. So for all these complications, we have to monitor the patient very meticulously. So after dealing with the complications, what are all the weaning strategies for weaning the patient from ECMO? If it is a veno-venous ECMO, during the weaning trial, when the patient started showing improvement, if the lungs are improved, we can see it by seeing the x-rays and certain lung parameters on the ventilator. If the lung compliance has improved, means we can try reducing the sweep gas, and we can give a complete sweep gas off trial. If the patient can able to maintain PCO2 levels and PO2s after completely off the sweep gas, we can say that patient is ready to wean from the ECMO. Whereas in VA ECMO, we will reduce the flows flush, and we'll see is there any hemodynamic instability or not, and again we will check the echo for contractility of the heart. If the contractility is good, even after reducing the flow, patient hemodynamics are stable, we can say that patient is ready to wean from the VA ECMO, and we can decannulate the patient. So what are all the clinic summary, clinical takeaways in an ECMO patient? It's always important to have select a proper patient for initiating the ECMO, and we have to understand the physiology of the ECMO, and proper monitoring is very, very important, and we have to understand that ECMO is a bridge, it's not the end for the treatment. Here are a few cases which we managed in our hospital. It is a survival of a young who is having a left main coronary artery occlusion. So usually if there is a left main coronary artery occlusion, usually they won't reach the hospital. If they reach the hospital also, the mortality will be very, very high. Here is a 35-year-old male patient with no known comorbidities. Came to our hospital with 10 hours of severe chest pain and 1 hour history of severe breathlessness. By reaching the hospital, he is in severe hemodynamic instability and in almost gasping state. He was in severe acute pulmonary edema. So immediately we intubated the patient, started him on vasopressor. After that, after stabilizing meanwhile stabilizing the patient, we have taken the ECG. So you can see the ST elevations in lead 1 AVL with reciprocal ST changes. So it is a left main equivalent. Immediately from the ER itself, we have taken the patient to the cath lab for primary coronary angiogram. Angio showed the complete cutoff of the left main coronary artery, you can see. So immediately there is a thrombotic occlusion of the left main coronary artery. Immediately thrombus aspiration was done, followed by balloon angioplasty. As there is a huge thrombus burden, intracoronary tenecteplase injection was given. This is post-POBA thrombolysis. You can see the opening of the left main coronary artery and you can see the perfusion. So as the patient still in the cardiogenic shock, IABP was inserted. Despite of achieving the TIMI 3 flow IABP insertion, still the patient condition deteriorated in the ICU. His inotrope supports has gone up. Patient lactic acidosis is worsening and patient is going into acute renal failure. So we thought, despite of everything, the patient is not showing any signs of improvement, and because his cardiac functioning is not yet improved because he is in a cardiac stunning. So immediately we initiated him on VA ECMO. So within 5 days of initiating the VA ECMO, his cardiac condition has improved, AKA resolved. He is completely off inotrope. We can able to wean him off the ECMO by day 6, and patient get discharged within 10 days. So speed is life. Here immediately we have taken the patient for percutaneous angiogram. Immediately we have revascularized the vessel. But there are certain things beyond stunting, like assist devices, mechanical circulatory devices like IABP and VA ECMO in case if the patient is not improving. And complex critical care is also necessary in such a patient. So after 4 weeks, we did a repeat angio also. It showed the slow flow in the coronary vessels. The patient was doing good. This we published also. Another case, this is about viral pneumonia with severe ARDS. Here is a 14-year-old girl who is a known diabetic with poorly controlled diabetes, came to our hospital with fever, breathlessness, cough since 1 week. Initially she went to some other hospital. You can see the x-rays. Within 2 days, 3 days, there is a rapid progression of the pneumonia. So there she got admitted within 1 day because of respiratory worsening. They started her on NIV and she didn't tolerate the NIV. Immediately they have intubated the patient. Post intubation, she is unable to maintain the saturation. Her PF ratios were only 52. Meanwhile, patient developed hypotension, started her on inotrope. So as patient is on severe hypoxia, patient was referred to our hospital for further care. On receiving to our hospital, patient's PF ratios were only 36. Initially we tried prone ventilation, but still not much improvement in the prone ventilation. So you can see the X-ray at the time of admission to our hospital. So immediately we initiated the patient on VV ECMO as she met the criteria for VV ECMO. She progressed very rapidly over 3 days. In the same manner, she recovered very fast because usually for any viral pneumonia on VV ECMO, it takes usually 10 days to 14 days for the recovery, but she recovered within 1 week. You can see the improvement in the chest X-rays from upwards to the down. This is after initiating the VV ECMO. So on day 7, we can able to wean her off the ECMO, and on day 19, we can discharge the patient normally. Here one more thing is, by the time she received to our hospital, her saturations were only 65, which is such a severe hypoxia also, her lactates were normal. That means she is still, that end organ perfusion she can able to maintain, and we initiated the ECMO at the right time. That is why we can able to wean her off the ECMO very fast. So the timing of initiation of ECMO is also very important for early recovery. The third case, this case was done in Aster Ramesh Hospitals, Vijayawada. This case is about thyrotoxicosis induced severe heart failure. Here is a 37-year-old known hyperthyroidism, dilated cardiomyopathy, came to our hospital in a collapsed state. Immediately patient was intubated, started him on inotrope. Echo was showing global hypokinesia with severe LV dysfunction, severe MR and severe TR. you can see, TSH levels were very low. So patient was in almost severe thyrotoxic storm with refractory cardiogenic shock. So this patient is on triple inotropes. Even with optimal medical management, his shock is not improving. So initiated him on veno-arterial ECMO. So as the strong period we can able to handle, because in thyrotoxicosis it's a high cardiac output state. So that high cardiac output the heart cannot tolerate. That's why the patient went into severe cardiogenic shock. So as we handle the thyrotoxicosis storm with the medical management, slowly he started improving the cardiac function. After 96 hours, his ejection fraction improved to 35%, and he is off inotropes, and AKA also improved. So within 96 hours, we can able to wean him off the ECMO, and patient got discharged on day 6. So mechanical circulatory support as a bridge to the recovery. So you can see the improvement at the time of discharge, his ejection fraction improved to 55%. Here is the last case. This is about this case was done in Ongole Sangamitra. So this patient also presented to our hospital in a cardiac arrest state. He is having right femoral DVT with acute pulmonary embolism. So this patient was when coming to the hospital, he is in a PEA cardiac arrest. So immediately CPR was done, patient was intubated and thrombolized with a tenecta plate. But luckily this patient got extubated within 4 days, and shock also improved. Usually in severe pulmonary embolism with cardiogenic shock, these patients will need a VA ECMO. But this patient could able to come out of those cardiogenic shock easily with the thrombolysis alone. But after 3 days again he got intubated for acute respiratory distress. So because patient had a secondary bacterial infections, he went into acute respiratory failure. Initially he was responding to the prone ventilation, but after 1 week he is not responding to the prone ventilation, and his PF ratios got worsened. So this patient has to get initiated on VV ECMO on almost day 7 of the intubation. But this patient, as he received thrombolysis, he was on anticoagulation. On day 3 of ECMO, patient started having thrombocytopenia, and he had a bleeding complications like severe pulmonary hemorrhage he was having. And we thought, and he needs a multiple platelet transfusions also to maintain to correct the thrombocytopenia. This patient ultimately had, we suspected heparin-induced thrombocytopenia, so started him on bivalirudin infusion. After starting 3 days of bivalirudin infusion, his thrombocytopenia got better. This patient decannulated on day 10 of the ECMO and discharged home safely. So few things about the eCPR. So now main focus is on the eCPR, and there is a lot of data on the eCPR also. So eCPR is nothing but the rapid initiation of the VA ECMO while doing the CPR itself in patients those who experiences sudden unexpected cardiac condition, those who are having an underlying treatable condition for the cardiac arrest. So what are all the indications, or how we will initiate a eCPR? So the no flow time should be less than 5 minutes for initiating the eCPR, and the decision for initiating the eCPR should be taken within 10 to 20 minutes if there is no ROIC is achieved. And we have to complete the initiation of the ECMO within 60 minutes, then only the results will be good. So while continuing the CPR itself, we can initiate the VA ECMO in these patients for better results. So what are all the inclusion criteria? Age should be less than 70 years, and it should be a witnessed cardiac arrest, and the no flow interval should be less than 5 minutes, and we should have a reversible pathology, and there is no known any aortic valve incompetence. Thank you.
Thank you, ma'am. Now the session is open.